Welcome to part 2 of Understanding Mental Health for the Level 2 Adult Care course. So in part 1, we covered the legal context of mental health and what we mean when we say mental health versus mental ill health. In this section, we're going to cover the social context of mental ill health and how mental health care has changed over time. So, the first thing we want to talk about is the social context of mental ill health. And this is the part where you pause the video and make some notes of your answer for this question before we go on. You want to describe the impact of social and cultural influences on mental ill health. So try and think of factors that would impact, social and cultural factors that could impact on mental ill health. And pause the video and then come back. Give yourself about 2 or 3 minutes to do that. Okay, so describe the impact of social and cultural influences on mental ill health. So if we take cultural influences first, it's important to remember that the cultural view of mental health conditions is not consistent across the world. So different cultures can see mental health and symptoms differently. For example, here we have hearing voices. Now, in countries like Chennai, India, and Ghana, people might hear voices, but they won't have the same negative feelings about it as they might in Western cultures. Now, this is because traditionally in these cultures, hearing voices is thought to be like past loved ones or ancestors visiting or deities visiting or playful spirits is a common one. And it's not culturally seen as a bad thing in these areas. So people aren't told to stop or that they have to shut them out. Whereas in Western cultures, traditionally, historically, people thought that this was maybe bad spirits or it was a sign of possession. And there was a lot of stigma around hearing voices. And it's a very negative thing. People feel badly about it, and then they hear more negative voices, it seems. It's kind of hard to put a chicken and the egg, which one came first, on this one, whether it was the hearing voices, the negative voices came first, or whether it was that people felt bad about this, so it became negative. But between different cultures, because there are these different traditions in the culture, then there is a different outcome for people. Like a lot of people hear voices in Chennai, India, or Ghana don't say that it makes a huge impact on their lives, that they're pleasant enough voices, so they carry on with their lives and they're not scary to them. Now you also have different cultural views about how mental illnesses should be treated and how people should be supported. Like in some Nordic countries, they have not got so much a history of institutionalization as there is in the UK and Ireland, and would instead lean towards community support for people. So with schizophrenia, for example, this was tracked and it was found that they had greater community support, greater community integration, and therefore better outcomes and less hospitalization. Whereas in the UK and Ireland, there would be more of a history of institutionalization, maybe less community support, and therefore the risk of hospitalization is a bit higher. Other factors to consider would be cultural stigma. So if, again, it's very similar to the hearing voices thing. In Western cultures, there's a stigma around hearing voices. There'd be a stigma around any sort of mental illness traditionally. Long ago, there used to be what they called a moral theory of mental illness, which was basically that mental ill health came from having poor morals and poor character. So there is historically a stigma in the culture, and it wasn't that long ago. It was only a couple of 100 years ago, um, depending on what area you're in. We could also talk about understanding symptoms. So different cultures, again, would have different understandings of symptoms. For example, in Japan, a study found that when people would go to the doctor because they've got an anxiety, they would describe their physical symptoms. They'd describe dizziness, stomachache, rapid heartbeats, sweating, all of this, but they wouldn't describe any emotional or psychological symptoms until they were led to describe it. So with that, it can be hard to treat if the doctor, let's say, didn't push and look for the psychological symptoms. They might just try and treat it as a physical illness and try and find out what's going on there, where perhaps some CBT or cognitive therapy would be more helpful. It just depends. Now, you also have community support and resources to look at. So where there is more community support and community resources available, you would have better mental health outcomes. For example, if the only treatment available for mental health is in hospitals, then people are more likely to be hospitalized for mental health problems. If you have community treatment centers available, and people are more likely to use them, there's more opportunity to reach people before things get too bad that they need to be hospitalized. And also, if somebody was hospitalized and on release there was no community support or resources to help them, then that is often a problem. You need what's called step-down services in order to help people reacclimatize to being in the community. When people are in hospital, it's a very safe environment. There are people keeping an eye on you. There's a routine. And if you leave and there's no support, then that's a high-risk time. So there needs to be community support, community treatment centers. There needs to be support workers available and other resources like support groups or day groups where people can socialize. Okay, your next question is describe the impact of media influences on mental ill health. So having a look at these headlines, they're not painting a great picture. I've included the seagull thing down there because it does say psycho. And the word psycho is entirely overused and generally annoying to me, because it puts down any sort of bad behavior to a mental health problem, which not necessarily the case. I would also have a look at the 1,200 killed by mental health patients, and I would wonder about those statistics. For instance, we can see from the small type below it that it's over 10 years. I'd wonder how many murders or killings were not done by mental patients. I don't like the term mental patients either, mental health patients during that time as well. As we can see, if you're reading this, you probably would not come away with a great impression of mental health. So the problem with this is that it might make the general public feel afraid of people with mental health problems. It might make them distance themselves from family or friends that are experiencing mental health problems at a time when they do need social support. They might need just distracting from their problems for a while, and they'd need to be engaged. But people might feel afraid and they might distance. The individuals themselves, they might feel like they're now more of a risk to people now that they've developed a mental health problem based on that. Or they might be afraid of people finding out that they are having difficulties or that they're having treatment. So that it adds to maybe a sense of guilt. And we know that guilt is associated with anxiety and depression. So that wouldn't be very helpful. It can lead to misconceptions about symptoms, about what mental ill health looks like, um, and it can lead to people not knowing where they can go for help. On the positive side, however, in the last decade or so, I think we've started to see a shift in how mental illness is dealt with by the media. There's a lot more celebrities now that would be talking about their own experiences of mental ill health. Like at the time I'm recording this, the TV station Dave has been running a few programs lately called I think it's Comedians Against Living Miserably. So it's comedians talking about their experiences of mental ill health, and it's kind of engaging because it's meant to be funny. It's not all doom and gloom, which some documentaries about mental ill health are a bit gloomy and wouldn't engage as many people. So there is more to it now. There's more engagement now, and people are understanding that if you're going to have this conversation about mental health, that it doesn't have to be this very serious thing. People's experiences of mental health or mental ill health tend not to be that everything is miserable all the time. Sometimes people could have really bad depression, but they could have a good day in the middle of it. So it does help to raise awareness, I think, and maybe help people to talk about their problems. Because if people watch the comedians, maybe they watch these channels on what programs on whatever channel they're on with their friends, maybe they'd start to talk about it. So it can have a positive impact on mental health that way. Now, this question is very similar to the last ones if it's answered with examples in the last ones, then you wouldn't have to do it again. Now, this one does say explain. The last questions, we can go back, were describe. So when you have an explain question, you'd want to give some examples, preferably from work if you can, of how this could impact. We've got some examples, some summary there for you that you can use as well. Let's go on. So we want to understand how mental health care has changed over time. You could pause again at this point and make some notes because we want to talk about the historical approaches to care and the use of community care. So making some notes, do you know anything about the history of mental health care? So I'll let you pause for 2 minutes again and make your notes. Okay, now that you're back, I will tell you a little bit about the history of mental health care. So over basically millennia, there have been three main theories about the causes of mental health, and that has impacted on how people think mental health care should, or mental health should be treated. You have the supernatural causes, the somatic causes, or the psychogenic causes. So supernatural, I think we can figure out. Somatic, if you've ever heard the term psychosomatic, as in his limp was psychosomatic, that means that the limp was caused, the physical outcome was caused by a psychological cause. When we say somatic, as in mental illness was somatic, we mean that the mental illness is caused by physical causes. Or you've got psychogenic, which is that it's internally generated. It's generated by the mind. So if we look at some examples of what people thought of somatic causes, long ago, the Mesopotamian, the ancient Egyptians, and the Greeks thought that it could be somatic causes for mental ill health. For example, the Greeks called it hysteria or wandering wombs, as in that the womb would detach itself or something from its normal place and go attach itself to the other organs and cause problems. Like it could go attach itself up by your lungs or on your liver and cause psychological problems in that way. And then they would try and treat it with smells. So they thought that you could lure the womb back to its normal place with pleasant smells and then just or like scare it away from your lungs with unpleasant smells. How that was supposed to work, I'm not sure, but that's what they thought. Trephination, sometimes called trephination as well, without the H sometimes, is literally drilling holes in the skull. Now, it was, in some cultures, it was thought to release evil spirits. In China, around, as we say, 2700 BC, it was supposed to improve the balance between yin and yang somehow. Now, trephination does have some actual medical uses. If somebody has an infection or they've had an injury and the brain is swelling, then trephination, very useful. It lets some of the pressure out because that is the problem when the brain is swelling. For mental health problems, again, maybe the people saw similar behaviors between, let's say, delirium for an infection and between, let's say, what we'd call today schizophrenia. Then maybe they thought the same thing would work. Okay. Moving on, in medieval Europe, they went back to supernatural causes. So they thought somehow that mental health symptoms could be demons or evil spirits. And treatment in these cases were prayers, relics, atonement, confession. People were often not treated very well in these cases. They might be locked up, they might be driven out of their villages. In general, it probably wasn't the best time for that. The 15th to 17th centuries as well, demonic possession and witchcraft were the theories. And in those cases, like the witch hunts and witch burnings became popular. Like there were books being published about how to find and hunt witches and all sorts. And they estimate that at least 100,000 witches were burnt at the stake. So that wasn't great. At the same time, I believe it was around the 1600s, there was at least two physicians of the day suggesting that it was not due to possession but due to physical causes. But the Catholic Church at the time shut that down and ordered them not to publish their books. From about the 16th century, again, it was somatic causes. There was a bit of crossover depending on the area that you're in. From then on, somatic causes became the popular theory, and treatments included bleedings, general physical treatment, and generally not great. Asylums were created. So asylums weren't for treatment of mental ill health. They were for the confinement of people who were affected by mental ill health. So they were put in place to keep people with mental ill health away from the public. Now, we know that they weren't great places. They were very dehumanizing. People were shackled to the walls and all sorts, rather than actually being a place of treatment. Bedlam, for example, people were, the public was allowed to come in and view mentally ill people, and they paid a fee to come in and view people. So that wasn't great either. From the 18th century, things started to get a little bit better. Various people began to protest the poor treatment on humanitarian grounds. In Yorkshire, for example, the Quakers established a retreat, so like a big kind of farm setting where the care was about dignity and courtesy. And the people with mental health problems would come there for a quiet life, some structure, and would work on farms. Now, this was popular in various areas, and there is some merit to it. It was definitely more dignified than asylums. Let's see, from the 19th, 20th century, psychoanalysis and psychodynamics became more popular. It was Freud and various people associated with him. They started looking to psychogenic causes, that mental ill health came from internally. And let's say Freud, for example, thought that mental ill health would have come from poor adaptation when people were growing up, that something didn't quite click when people were growing up. There were other schools as well, such as behaviorists, that thought that all behavior is learned and all behavior is a response to stimulus. So something happens, you either have a negative or a positive outcome, and you learn to do this or to avoid it at all costs. When you're avoiding something at all costs, they think that's a phobia. Okay, so on to the UK and more modern treatment. The National Health Service was established in 1948. And in the 1950s, some drugs that were actually helpful were introduced. There were various, it's a bit complicated. There were various factors going on at the time. Mostly people feeling that the old Victorian asylums were inhumane and that they weren't a great idea, so they wanted to shut them down. There was also the costs, I believe, was a factor in that decision, the costs associated with running them. So people thought it would be better for the individuals and also more cost effective to aim for a community model. So in, let's see, the 1959 Mental Health Act was actually the first mental health legislation to clarify reasons why an individual might need to be admitted to hospital and treated against their will. Before that, the decision was often made by the families of the individual, and again, it was very open to abuse. There wasn't any much oversight in this. Somebody could be hospitalized against their will and they might never come out of the hospital again. In 1962, the hospital plan was announced, and it was predicting the closure of half of all mental health beds by 1975. Now, from this, led to the development of community-based services. So day services, supported housing, the community-based mental health nurses. So those would have been very good developments. Now, the problem that led to that, well, that led on from closing all of these beds at once, was that there weren't really enough services in place, that a lot of people slipped through the cracks. A lot of people ended up homeless because there wasn't anywhere for them to go, or they couldn't really cope in the community after they had been in such structured environments, for some of them for many years or decades. In general, the long-term outcomes, they were tracked, and in general they were determined to be that most people managed okay from there. Since then, we've had early intervention and the crisis resolution teams. They have been a good resource for people who are in crisis. So if somebody is really struggling and feels that they're possibly a danger to themselves, they can call the crisis teams that still exist, and they can help them or direct them to services. From there as well, more services are available now. CBT, or cognitive behavioral therapy, is popular. Counseling and other talking therapies are also popular. Now, CBT is one that is growing in popularity because it's an evidence-based treatment. It's meant to run for 12 weeks, and you're meant to have improvement within those 12 weeks. So it is popular in that it is tracked, there are goals, there's a structure to it, and that is why the NHS likes it. Now, it doesn't work for everyone. Some people will prefer a talking therapy like DBT instead, or counseling. But I would be in favor, mostly, for the most part, it's not for everyone, for the most part, I'd be in favor of evidence-based treatments as much as possible. That some services can be provided over the phone or by video chat now is a very good development. Let's say for people who have mobility difficulties or agoraphobia or social anxiety, it can be a lot easier for people to access. Or even web chat. There are some services that will offer some support by web chat as well. So there are good developments happening there as well. Another development is support workers who work with individuals with mental health problems in the community as well. They would, similar to other disabilities, that they would come out and support them. But they are available for mental health too. So, after the history, we want to explain the impacts of changes on individuals in mental health care. Now, it's very possible for you to answer this question and the other question together if that's your preference. Just make it clear that that's what you're doing. But we could have a look here. So the closure of the asylums, it led to high rates of homelessness among former residents shortly after the closures. That would have been a negative impact, but the greater emphasis on human rights and on recovery and being independent is surely fairer. It's less open to abuse. That there are, since 1998, we have the Human Rights Act, which says that people can't be detained without cause. We have the Mental Capacity Act, which says we've got to assume that people have the capacity to make decisions for themselves. Whether it's the decisions that we'd make or not, it can be different. Early intervention teams and services were also a good development. The earlier you would start treatment for a mental health problem, the less likely you are to need hospitalization later on. It's where things are left to fester that problems really develop. Now, they can't do everything. A lot of people won't be referred to services until things are quite bad, but it is better to have early intervention. The development of CBT and the popularity of it is also quite good. It's also good that people are aware now that this treatment is available, that it is out there. People can ask for it from their GPs, they can ask for a referral. And with CBT and evidence-based treatments, it seems like it's less open to abuse, more likely to have results. People are tracking the results. If results aren't there, then adjustments should be made. It is very reasonable to expect a change in 12 weeks. It won't happen for everyone, but you'd expect an improvement in 12 weeks with CBT. It's often very good for lower level mental health problems, like lower level anxiety, mild depression. CBT can help people a lot, and the increased availability of that is great. Care plans, that everyone who needs care should have an individualized care plan, is a very good development. Where it used to be that individuals, well, that a care home or a facility or a hospital would say, we're providing this facility, and the local authority, we're providing this service, we'll do A, B, and C, and then it would be up to the local authority to buy into this, and they'd buy so many places, and then individuals would have to slot in as best they can. Now that we have care plans for the individual, it's not just we provide A, B, and C and everyone has to take that. It is a matter of, well, what does this individual need? Are we set up for it? Can we set up for it? Do we need extra training? What can we sort out? That would be far better. Also, that the individual has to be involved in the care planning. It's not decisions being made in a room without the individual with the mental health concern. It is the individual is involved in this. Why that's particularly important is that if the individual isn't involved, they are far less likely to comply with the treatment plan. As most people don't like being told what to do, for one thing. And for another, it won't have accounted for what they actually need. Let's say with depression, low motivation is frequently reported with depression. So if people aren't involved in the plan and it's not been tailored to them, then it probably won't work. And that they might be labeled as being non-compliant rather than, well, the plan doesn't work, we have to change the plan. Okay, so that is the end of our lesson on mental health. I hope it's been useful to you. Complete your workbooks and send them in. Thanks very much.